How do dry chamber results correlate from mice to those results that are found in humans? What positive controls should be used, or maybe other controls as well, but what controls should be used to bridge the models?
Excellent question, and I think that for years there's been a tremendous challenge in having a successful preclinical study then demonstrate efficacy in a human trial. We've had the ability or the opportunity to study 3 drugs now that were screened in the mice model dry eye chamber and see how that correlates with the human trial. One that was presented publicly was looking at the Alacrity Biosciences product, doxycycline for dry eye, and that was looked at in the mice or mouse model, demonstrated strong effects on staining, and then we had the opportunity to do that in the CAE model, and also had confirmatory effects on not only staying in the chamber but symptomatology in the environment. So I think that's probably the strongest correlation we've had, and we've had a couple examples to confirm that. Controls that could be used, maybe Stephen, if you want to comment on what you'd see in the earlier preclinical models and how we can correlate that to.
Well, I mean, the more research I do in this area, the more I realize that environmental conditions are crucial, and controlling those is a very big factor, and that's why maybe, in standard dry clinical trials, you have to enroll hundreds of patients, and you can certainly maybe decrease the number of patients that you need if you use an adverse environmental chamber like the ORA chamber, because at least you're selecting for responders to that environmental stress condition. So there's no question in my mind that's a key thing. I think one of the lessons that I've learned, if you're doing clinical trials that take months in the real world, especially if you live in an area where there's a lot of climate change, like the Northeast, then the change from spring to summer to fall is going to be huge in terms of humidity, wind, and other factors. And you're going to have to work against those day-to-day variations in order to show an effect of your drug.
I would say this is probably the first time I'm aware of where an animal model was developed, both Ray's and Steve's model, developed from the human model. Normally it goes the other way around. And I think the fact that those models are so important is that it's harder to do high throughput and to file INDs on everything you want to test. And certainly if you can do high throughput through the dry mice models, a mouse is not a man. I saw someone say that, and I think we all subscribed. That was yours. That's like Wiley's. Most drugs aren't better than placebo. Very, very to the point. The fact is that if you get some effect in that, that's a good. It's a good segue into doing the same thing, putting the man in a similar type of situation. We don't put atropine on the tail of the subjects, but short of that, there are some significant similarities. Wiley, your thoughts on how you look at when you're evaluating, say, an IND and or end of phase 2 meeting, looking at. Do you go back and look at the preclinical and try to see?
I'm actually in the minority. I have frequently said if I waited till I understood how various products worked in animals before I allowed them to go on to human trials, we would have 1/10 the products that we currently have. So I've not set that as a criteria. If the individual sponsor thinks they have enough of a rationale for proceeding and we have sufficient monitoring in place, I'll normally allow the trials to go on in humans.